And I hope by now everyone get my slides. I send it as a PDF in the chat. So you can just follow me, the presentation. And this is a follow-up lecture for the previous one that we did last week or the week before about diarrhea. So we presented last time acute, and we mentioned about the definition of diarrhea and also the acuteness. Is it acute? Is it persistent or chronic? So the chronic diarrhea by definition is more than 4 weeks. And we mentioned already that diarrhea is always increase the frequency and increase the consistency. So loose stool and more frequent. And we gave 2 examples of something that can mimic diarrhea, which is like pseudo diarrhea, which is like frequent bowel movement, like patient who have IBS, frequent defecation, but without really having loose bowel movement. So we'll be discussing today the chronic part, and again, the correct answer is B. It is more than 4 weeks. And hyperdefecation, we discussed that with pseudo diarrhea. Stool incontinence is another differential that you have to keep in mind. Some patients will mention that they have diarrhea, but in fact they have stool incontinence due to sphincter issue. And diarrhea is a symptom, so we have to look for the cause for that. So chronic diarrhea, we mentioned that it has to be more than 4 weeks, and we would like to have always loose stool, and it's more frequent, usually more than 3 per day. The same slide I presented before, that there is a good intake, that we are taking liquids, and we encourage liquids between 2 to 3 liters oral intake, and there is endogenous from the saliva and secretions from the stomach, biliary system, pancreatic, and others that will reach up to 8. So most of this will get absorbed in the jejunum, and 2 liters will be absorbed from the ileum, and the remaining 1 liter will be absorbed in the colon, leaving only 100 ml or cc to be secreted in the stool. So usually in the stool will be less than 200. However, if there is more fluid that go to the colon due to any cause, any reason, either due to inflammation, poor absorption, or short bowel, or bile salt diarrhea, or anything, this will lead to stool actually getting more fluidity, and it will be more than 200 fluid in the stool. Always the history is the key in everything you are doing. So number 1 issue, always you make sure that this patient has a real diarrhea. It's not something that can mimic diarrhea. And you differentiate, is it acute, persistent, or chronic? You classify the chronic diarrhea because it's more than 4 weeks to 5 categories. The first one and the most common one is actually the watery type, and subdivided into osmotic part and secretory part. And second differential is the motility, which is hypermotility, and the classical example is hyperthyroidism and patient with irritable bowel syndrome. Inflammatory diarrhea, and this is classical example we are seeing like an ischemic colitis and inflammatory bowel diseases and diverticulitis, they get diarrhea with it. So this is what you call it, inflammatory type of diarrhea. Fatty diarrhea due to fat malabsorption, and this is either due to biliary issues, due to pancreatic issues, or short bowel syndrome. And factitious, which is not really uncommon. Sometimes the patient will use either intentionally or unintentionally the medicine or herbs or something that they are taking it for, like constipation or some sort of health, improve sleep pattern, or doing something like that, or they are taking it without really recognizing it, and this is sometimes really cause diarrhea. So the osmotic part, it is some osmotic particles that will go and retain the fluid within the intestine. These are the osmotic parts. Once the osmotic load reach the colon, this will retain or reach even the small bowel retain and to maintain the interluminal osmolarity equal to the plasma. As you know, our plasma osmolarity is around 290, and the osmotic load will retain actually the water to keep it the same in the stool. So usually when we drink water like 3.5, we like each 1,000 ml will be divided into 90 are needed to keep actually 1 milliosmol of the ions in the body. Always we look for clues in the osmotic diarrhea, and the most important clue is the clinical part. You ask the patient when they fast Ramadan, for example, there is no diarrhea in the daytime. But when they break the fast after evening, they usually have loose bowel movements, and this is due to ingestion of the osmotic material. Classical example is like ingesting magnesium. Magnesium is a medicine that can be used for sleep pattern, for laxative sometimes, for antacids. So if the patient is taking it in excessive amount, this can lead to osmotic diarrhea. Others like phosphate, sulfate, lactulose, and sometimes not due to ingestion, but due to issues with like absorption. And the most important part, differential is the carbohydrate. Carbohydrate malabsorption, and we see it in patients who have, for example, lactase deficiency, lactase enzyme deficiency, fructose intolerance, using sweeteners like sorbitol or mannitol, and others like patients who have malabsorption due to celiac disease or a pancreatic exocrine dysfunction or deficiency. On the other part of watery diarrhea is not osmotic, is due to secretions, and this is usually large volume, and it is mediated sometimes by hormones. Classical example is we see it in like polyps, they call VI pomas in the colon, or carcinoid tumors, or Zollinger-Ellison. As you know, Zollinger-Ellison is the gastrinoma that can lead to ulceration and hypersecretions and leading to chronic diarrhea. Adenomas is a good example. Bile salt malabsorption, we see it, for example, in patients with ileal resection, post-laparoscopic cholecystectomy, and patient, usually the bile salt will go to the colon and irritate the colon, and this will lead to a secretory type of diarrhea. So if the patient stopped eating, even if there is bile, it will be less amount, and this will lead to less diarrhea. However, secretory diarrhea will improve again, but not to the significant level like osmotic diarrhea. Osmotic diarrhea, definitely the patient will have significant improvement when they fast. But secretory diarrhea, it might improve, but most of the time will not improve compared to osmotic diarrhea. Medications, there are medications that can lead to secretory diarrhea, non-osmotic laxatives, and some infections. The other type now, we are leaving the watery diarrhea, we're heading to the inflammatory or like purulent diarrhea or exudative diarrhea. There is a pus, there is blood in it, and the classical example is inflammatory bowel disease. Celiac disease is rarely causing like inflammatory type of diarrhea, and it's complicated by like ulcerations or malignancy, microscopic colitis, chronic infections like schistosomiasis, for example, giardiasis, amoebiasis, ischemia, and there are types of ischemia that affect the bowel, can be arterial, can be venous, and also radiation therapy. What we mean by radiation is the treatment for like tumors, like cervical cancer, like lymphomas. They give treatment with radiation, and this will lead to impact on the mucosa and leading to inflammatory type diarrhea. The motility disorders, I think you know about hyperthyroidism, diabetes can lead to constipation or can alternate with diarrhea, and also irritable bowel syndrome using prokinetic drugs and post-surgical like patient who underwent gastrectomies and vagotomy. The least common one is the fatty diarrhea, which is the patient sign that they will go to the washroom and they will defecate, and it will be difficult to flush from the toilet. due to high fat content. And the classical example is the patient who has pancreatic exocrine dysfunction due to chronic pancreatitis, for example, due to alcoholism. Mucosal diseases like celiac and small intestinal bacterial overgrowth, and lack of bile due to, for example, biliary cirrhosis, and this will lead to fecal fat concentration will be more than 9.5 grams per 100 gram of stool. So the malabsorption syndrome is leading to fatty diarrhea, and this can be also due to small bowel mucosal diseases. And the classical example will be celiac disease, Weber's disease, eosinophilic gastroenteritis, or if there is lymphatic issues, lymphatic obstruction in the abdomen. For example, lymphomas and carcinoid that will lead to blockage of the lymphatic drainage. This will lead to fatty diarrhea. And we mentioned already mentioned bacterial growth as well as pancreatic and biliary disorders. So Alpines, this will just give you that the diarrhea is not due to usually one cause. Chronic diarrhea, it can be the immune system, it can be due to lumen defect, it can be due to blood flow, it can be due to muscles, it can be due to epithelium or endocrine or others. So this table basically summarizes the most really common cause of diarrhea, chronic diarrhea, and I just put for you osmotic type, fatty type, inflammatory type, and also the secretory type. So it's a long list, and the most common, as you can see, is the secretory type on your right side. How you evaluate? Again, evaluation of chronic diarrhea start from the history. You need to have really obtain a detailed and good history from the patient. Okay, so we need to know what caused the diarrhea, for how long the patient has it, what does it cause, is there any side effect, is there any complications from diarrhea. So we need basically to know when did it start. If a patient will tell you, well, since childhood I have this diarrhea, you should think about congenital type, like congenital chloride diarrhea, which is inherited as autosomal recessive. And the gene is SLC26A3 gene on chromosome number 7. And if it's abrupt, just sudden onset, this is usually acute. It will not be chronic diarrhea, but it can lead to chronic diarrhea if this is ignored or the reason or the cause not resolved. Gradual, most of the cases of chronic diarrhea start with mild, then moderate, then become severe. Then you classify, is it watery, clear water, there's no pus, there is no blood, or there is blood in it, or there is also fat, and the patient described it that there is fat globules, or it is really difficult to flush. The volume, if this is going to be flush small bowel or secretory type, it will be large volume. If it's osmotic, will be also small volume. What precipitate? Is it really improved with food or getting worse with a specific food? Sugars, like chewing gums, any of these. You ask the patient what make your diarrhea improve, what make it worse, is there is any clue, so the patient will help you. And relation to meals, if this is improving with fasting, maybe this will indicate osmotic type of diarrhea. We ask about sorbitol, fructose, lactose intolerance. If the patient is having nocturnal, what we mean by nocturnal is patient is waking up at night to go to the washroom to defecate because of diarrhea. Okay, not to pee or just to have like abdominal discomfort or gases. No, they have to have like nocturnal diarrhea, especially if it's more than one. Okay, this indicates really it's significant, and this is really need to be investigated urgently. Other symptoms like the pain, the weight loss, what is really an alarm feature that you should always consider, like malignancies, inflammatory bowel diseases, and celiac disease and pancreatic disease. The patient has bloating and gases, belching, having a lot of flatus. Think about bacterial overgrowth or carbohydrate malabsorption. And again, other clue, you ask about tremor. This might indicate hyperthyroidism. There is a rash. There is another condition that For example, celiac disease has dermatitis herpetiformis, inflammatory bowel disease has skin rash. There are 10 types of skin rash associated with IBD. So you need to ask about skin rash and also joint pain that can be associated with IBD and other conditions. Dig deep in medications, ask about over-the-counter, herbal remedies, social, water source, drug abuse, alcohol, family history also of GI diseases, in particular IBD and celiac, congenital chloride diarrhea since childhood, and IBS. You need to complete your history by asking the patient if he or she underwent like surgeries, or they have medical conditions like diabetes mellitus, thyroid diseases, any surgeries like cholecystectomy. As I mentioned, cholecystectomy, about 10 to 20% of them, they will have bile salt diarrhea. Any radiation to the abdomen due to lymphoma or like uterine cancer or prostate cancer, and psychological if the patient is really looking up for the body image and they might consume something to induce diarrhea. So again, will summarize the medical history, looking at duration, epidemiology, presence of pain and bloating. You classify it, you look for alarm features, especially weight loss. Is there any change of diet, stress, or smoking? Like some patients, they might start smoking and this might actually provoke conditions like IBD, and smoking cessation might provoke conditions like ulcerative colitis. So we do still consider smoking cessation for all patients. Medications, chemotherapy, radiation, any surgery in the abdomen, consider it, get the detail of it, why it was done, is it complicated, and what type of surgery. Examination is not like acute diarrhea. You should always spend time on examining the patient with a chronic diarrhea, looking for manifestation of the cause of diarrhea, for example, IBD or celiac, looking for mouth ulcerations, looking for skin rash, joint examination, abdomen examination, look at the thyroid examination. The patient might have a condition suggestive of hyperthyroidism, and to examine the patient and find large thyroid or there is evidence of Graves' disease. In addition to that, look for the complication of the chronic diarrhea. So not only the cause, but also if there is any consequence. So if the patient has chronic diarrhea for like months or years and ignored, they might have deficiency of vitamins, deficiency of iron, and this will manifest as glossitis or like angular stomatitis, which is inflammation around the mouth. Rectal examination, or they call it digital rectal examination, is important. Look for fistulas, look for fissures, any features of Crohn's, abscess in the perianal area. Look for sphincter tone, make sure there is no blood, fecal induction, and examination of the abdomen. Also looking for ascites, because if the patient has low albumin due to chronic diarrhea, they might tend to have lower lymphedema and ascites. And again, examine the joint and examine the skin for any manifestation. I put here for you some examples like skin changes, celiac, look for dermatitis herpetiformis, other conditions, for example, you see arthritis. I look for IBD, Whipple disease, and some infections that might lead to arthritis. If there's a lymphadenopathy, think about lymphoma, HIV, and tuberculosis. This is an example. On the left side, you can see there is on the chin, you can see there is a marked redness on two sides, actually in both bilateral. This is erythema nodosum. And on the right side, you see there is also ulcer that you can see it's deeper than the one on the left side. This is not erythema nodosum. This is called pyoderma gangrenosum, and also seen in patients with inflammatory bowel diseases. What we need to do for labs, I need to do the routine labs, including complete blood count, looking for anemia, looking for leukocytosis or leukopenia, looking at platelets. Then I do the routine labs, looking for liver function test, kidney function test, and again, thyroid function test. Patients who have chronic diarrhea, I need to make sure that they don't lose vitamins. I need to check the vitamin B12, vitamin D, look also for the iron, the ferritin. And I need to test also the stool. Make sure that there is no infection at least one time. Exclude the infection, look for oviparasites, multiplex. Other one on the right side, it will be selective. So if you think that you have done all the investigations that came to be negative, you can consider HIV, celiac serology, looking at hormones, for example, gastrin, cortisol, Addison disease, rarely you see it, rarely present as a diarrhea, but in the textbooks still it's mentioned, and consider doing an imaging like CT scan of the abdomen and doing a colonoscopy and taking biopsies. So you need to always differentiate in watery diarrhea between osmotic type and secretory type. And how can we differentiate is by using the stool osmolar gap. So we have a case here. By the way, secretory diarrhea, you can see a lot of sodium, potassium, chloride, bicarb, and unmeasured osmosis on the osmotic type of diarrhea. But so the gap between the serum and this one will be small in patient with secretory type of diarrhea because a lot of secretions of potassium chloride will close the gap. So if the gap is large, you should consider osmotic type. If the gap is small, you should consider secretory type. And here is an example. So 50-year-old female with 6-month history of watery diarrhea. You check the stool sodium is 80, potassium is 50. So you need to calculate. 290 is a fixed number. This is your plasma osmolarity. You didn't need to test the stool because it's the same. And 2 multiplied by potassium plus the sodium and turn to be 20. Anything is smaller than 50, this is secretory. More than 100 or 125, this is osmotic, and in between would be mixed type. What can you do with the X-ray? Sometimes you can get a plain X-ray to look for like toxic megacolon, dilated bowel, or calcification. This patient has calcification in the pancreas. This indicates chronic pancreatitis. And this is, again, a classical example of patient with inflammatory bowel disease. You can see this is the colon, there is ulcer down, there is edema, there is erythema, and this is a classical. Once you take a biopsy, pathologist will tell you this is IBD. Celiac disease is another one, but you remember, we usually do our GI endoscopy for patients suspected to have celiac disease, looking for the villus atrophy in the duodenum and the duodenal bulb, which is D1, and in the second part of the duodenum. But this to be done as second step after doing the celiac serology. Celiac serology is the first step. If it's positive, you do the biopsy. This patient has also like a tumor in the head of pancreas, which is like gastrinoma, another differential for secretory type of diarrhea. So I'll leave you with this one, how to approach patient with a chronic diarrhea. So you start with the history, physical examination, doing routine labs, looking specifically also stool examination, especially in watery diarrhea. If this is a bloody diarrhea, there is no need to do it. Fatty diarrhea, no need. Only in case of watery chronic diarrhea. Then you classify it to watery, inflammatory, fatty. So how you treat it? So the treatment will depend on the cause. So what did you find in your colonoscopies, laboratory investigations, imaging? You treat it, okay? The most important is you look for the patient as a whole, hydrate the patient, pay attention to trace elements like selenium, the zinc. Also look for the B12, vitamin D, iron, and replace it if deficient. If there is infection, give antibiotics. If there is no infection, you can give loperamide to slow the bowel movement. And what you can use sometimes is look for like opiates. You can use it for patients with chronic diarrhea of unknown cause, or they are having it like for like short bowel syndrome. So you can use codeine. Bile salt or bile acid binding resin like cholestyramine is used for patients with bile salt diarrhea. Okay, usually we give 4 grams like 1 to 4 times daily. Okay, there is a nice article. It's really long, but it has nice graphs. Maybe you can look at it later on. Guidelines for investigation of chronic diarrhea in adults. This is from British Society. I think it was published like 2 or 3 years ago, but it has good algorithms. But I already mentioned most important things that you need to know about chronic diarrhea. So what's the take-home message? I think chronic diarrhea, you should know, is it diarrhea or not? Is it acute or chronic? Once you make sure this is a chronic type of diarrhea, you need to go and take good history from the patient, okay? Make sure it's not an overflow or incontinence. Classify the diarrhea. Is it watery, is it bloody or non-bloody, like fatty diarrhea, okay? Look at red flags. Is the patient losing weight? Is there an extraintestinal manifestation of IBD, like joint pain, eye manifestation, skin manifestation, oral ulcerations? There is any clue for this. So we look for common things. The most common cause of chronic diarrhea in our area is like inflammatory bowel diseases, celiac disease, like that. Review the medications. Ask the patient what they are taking, any herbal remedies. We have patients who are taking medicine or like herbal remedy called ashwagandha. It's a herbal remedies from India, I think. She was using it to improve the sleep pattern and like for fatigue and lethargy. And she developed diarrhea. And we didn't know about it until actually asked like 3 or 4 times. She said, well, I have, by the way, this one. When she stopped this, she improved. Diarrhea stopped. Okay, we did all the investigations. Unfortunately, at the end, we go back and ask her and we found this. And all the investigation came to be normal. So again, sometimes you do extensive investigation and you forget about the history. Okay, and thank you so much. I'm done with the lecture. So if there is any questions, I will be giving you like 5 to 10 minutes for questions.
Okay, thanks so much, Doctor. Doctor, regarding yesterday's lecture, is it possible to continue today, or should we just move it to tomorrow at the same time?
What is the time now, by the way? Let me see.
Now it's 3, so I think maybe we can finish with the lecture as well.
Yeah, no problem. Yes, we can.
Yeah,
So
it would be
if
beneficial for the student as well.
okay, let's just switch to